Hello, friends. Dr. David Katz, another COVID reality check. And per the title, I'm going to reflect today on left and right, right and wrong, front and center. In terms of left and right, I'm recently back from giving an in-person talk, my first since the pandemic began. I used to be on a plane almost every week to travel somewhere and speak at a conference, and of course, COVID has disrupted that. But this trip to Ohio was arranged quite some time ago when it looked like things might be winding down by now. Seemed like a good idea at the time. And so I traveled to Ohio, spoke at a conference, and encountered very different perspectives than my own, very different politics than my own. And I always try to listen very carefully to the opinions I don't already own, including about the pandemic. And got an earful of those related to public policy and so forth, and didn't agree with everything I heard or everything I saw, uh, but I did agree with some, and let me just present one fairly obvious consideration for all of you. Part of what has emerged, especially from the political left, if you will, in the United States, is the notion that any death related to COVID is a national calamity. We should prevent every last death. And in fact, I recently saw an announcement out of Quebec regarding zero tolerance. So zero deaths is the only acceptable threshold. And frankly, as a humanist and a public health physician who's devoted a career to protecting human lives, I can relate to that. But I can't relate to the incredible incongruities and inconsistencies with regard to all the other causes of death. In the United States, well over 650,000 people die every year of heart disease. Almost all of those deaths are premature. Almost all of those deaths are preventable by means readily at our disposal. And in fact, unlike COVID, which is an infectious disease that essentially inflicts itself upon us, deaths due to heart disease we inflict on one another, mostly for profit. Now, you could argue COVID is different because it's transmissible, but I beg to differ. Chronic diseases are transmissible. They're just transmitted via culture, via marketing, often by putting profit ahead of public health. They travel in social networks as opposed to viral particles in water droplets and vapor, but they are transmitted, and in fact there is a fairly robust research literature looking at the propagation of obesity and chronic disease through social networks. We transmit them to one another effectively. I won't keep going because I've developed this concept in my most recent written column, and per tradition, I will link to that here, and I hope many of you are amenable both to video and literary columns, and maybe you'll read that one as well. So I won't take this idea further except to say we have gotten so good at shopping for only the opinion we already own. We are selectively deaf to one another. We are selectively blind to one another. And as a result of our inability to listen to one another, we wind up tossing out the baby with the bathwater or preserving the bathwater with the baby. And the reality is, if we are willing to look both left and right across a spectrum of ideologies, philosophies, priorities, politics, there are merits and demerits in every point of view. And I would take this a step further and say that the responses to COVID at the policy level have in essence fallen victim to for every action an equal and opposite reaction, or as detailed in a book by Katz, who is an advisor to the Obama administration, going to extremes. Essentially, we have amplified one another's native inclinations and gone to extremes. And the extremes politically and in terms of policy are lock it all down or liberate it all. But the lock it down perspective has taken on moral overtones, an imperious morality and a sanctimonious self-righteousness to it. And again, if that's the basis for it, it's morally correct to prevent every death and protect every life, why don't we extend that to heart disease and type 2 diabetes, which, by the way, is rampant not just among adults, but among children? And that's entirely due to childhood obesity, which is entirely a byproduct of a culture that places corporate profit ahead of public health. So the hypocrisy is monumental and glaring. And it's not that the deaths from COVID are diminished. No, let us agree that every death in this pandemic is in fact a tragic loss. But then why don't we practice some version of the sanctity of life that is not quite so condition specific? When it becomes condition specific, you start to think, wait a minute, there's a different agenda here that isn't really about the sanctity of life. Because, yes, it's tragic. 250,000 people in the United States have died of COVID. 650,000 die of heart disease every year. Why isn't that tragic? Is it just because heart disease develops over a longer timeline than infectious disease? That doesn't make any sense. The deaths are premature. In fact, most deaths from heart disease are probably more premature than deaths from COVID. Is it because of transmission? And again, I don't buy that argument. On and on it goes. So looking left and right, I maintain, as I have from the beginning, that there are valid and invalid elements in everybody's argument. And we should be willing to listen to one another. It would be great if the pandemic had taught us that. So that's my view on left and right. And again, I commend to you the written column that further addresses those issues. What about right and wrong? Well, here I want to talk about me, what I was right about, what I was wrong about. I was wrong in my hope that the pandemic in the United States would be winding down by or about October 1st. Clearly, I was wrong. And I can explain the basis for that projection or extrapolation again, and it was looking at the arc of viral propagation in and around New York City, where there was high-level penetration, high-level exposure, where both young and healthy people and older, frail people were exposed all at the same time, and we saw hospitals fill up and ICUs fill up and a peak in deaths. And again, as I suspect all of you know by now, I volunteered to do shifts in an emergency department in the Bronx, so participated actively near the peak of all of that and saw it up close and personal. And there was a timeline to it. And then cases dropped off, and it seemed very likely that New York City and, frankly, much of the surrounding area, including where I am in Connecticut, had achieved herd immunity, not on purpose, but we'd achieved it just the same because we locked down here too late. And then as the virus started to propagate around the rest of the country, mostly due to indiscriminate returns to normalcy, basically just projected that the timeline, the peak in cases and hospital occupation and occupancy and deaths would be similar to the timeline in New York. And all of that was true. And that was the basis for hoping that we might be done on or about October 1st. Why was it so wrong? I mean, it clearly was wrong. I was wrong. It was my hope. It was an extrapolation, not so much a prediction, but I was wrong. Well, I was wrong because when I did the math, and I'll again provide a link to the video where I talk about the math, I had estimated based on mortality in the United States that at least 70 million Americans, and this takes us back 6 or 8 weeks, by that time, at least 70 million Americans had been exposed to SARS-CoV-2, maybe more, maybe even twice that many. But even if it was twice that many, so if 140 million Americans had been exposed to the virus when I was projecting we might be done with the pandemic here by or about October 1, it still meant 190 million had not. We're a population of roughly 330 million. Well, my expectation was that those people who had carefully stayed away from the virus this far into the pandemic would continue to carefully stay away from the virus. I really didn't anticipate that everybody would rush out into the world while there was viral circulation in their community. But that's what happened. So we wound up really with a perfect storm or a perfect confluence of untoward factors and behaviors. First, we had incredible inconsistency and conflict in terms of our political leadership. So a lack of leadership at the federal level, discord among different states, discord between states and the federal level, discord between federal agencies that traditionally manage these issues and the administration. And so, essentially, for want of grown-ups running the country, we had mayhem with regard to public health policy. And I think that frustrated everybody, and eventually everybody started to lose both patience and, tragically, trust. Sort of nobody left to trust. This accelerated the inevitable development of pandemic fatigue. That just happens because making your way through a pandemic is difficult and tedious under the best of circumstances, and we have not had the best of circumstances by any means. And again, I realize this may circulate far beyond the United States, but it's my compatriots here in the U.S. I'm speaking to about these issues in particular. So very bad political circumstances definitely compounding our pandemic fatigue. And then the change of seasons. And the change of seasons did not do anything in particular to foster the transmission of SARS-CoV-2, which clearly was circulating over the summer, except that it is potentially and inexorably bringing people more and more together indoors, essentially closer proximity, sharing air more than perhaps we did over the summer, and that's a contributor to increased dose of exposure and consequently increased infection. And then finally, and this absolutely is important, massively more testing than we did in the beginning of the pandemic. So what we're seeing now, so again, many reasons why the pandemic might have in fact ended on or about October 1 in the United States, as I had extrapolated, projected, and hoped. But I was wrong. It did not, and these are some of the reasons why. What about the current status of cases and casualties, and how does that relate to that initial projection? Well, the extremely high case counts are a combination of, again, massively more testing. So a lot of the cases we're finding now are asymptomatic or minimally symptomatic. And let's be clear, in the early going of the pandemic, we systematically overlooked those. In fact, there was a time when the CDC only authorized, because we had such limited testing capacity, only authorized tests in people who had acute symptoms. So we were, without fail, overlooking mild and asymptomatic cases. We're now finding them, and a very, very high percentage, frankly I think a significant majority of all cases of SARS-CoV-2 are asymptomatic or minimally symptomatic. So when you go looking for that, you find a lot more cases. And then that's compounded again by this indiscriminate return to the world and the change of season. So there are more cases. We're finding a massively higher percentage of the existing cases. So that accounts for the cases. Casualties are a different story. And this, I think, is a tragic consequence, again, of left and right political conflict, lack of trust, rigidity, pandemic fatigue. In many parts of the country, if young people were out and exposed to the virus and it were being transmitted, we'd have high case counts, but we would not be seeing hospitals fill up. Alas, it appears that in much of the United States, and frankly many other parts of the world too, both young healthy people and older people or people with chronic disease who managed to hide away from the virus until now are all exposing themselves to it together. And it is inevitably the older people and the people with a prior burden of chronic disease who are filling up hospitals and causing mortality to spike. It's unnecessary, it's tragic, it's terribly unfortunate, but it's this perfect confluence or perfect storm of factors that's contributing to it. So, again, I think the reasons why we could have put the pandemic substantially behind us by or about October 1 were valid. Didn't play out that way, so here we are, and as everybody knows, case counts are extremely high. casualty counts are high, but casualty counts are not high in New York City. They're not high in Connecticut. So our hospital census here in Connecticut is pretty normal. And by the way, and this is another pet peeve of mine. You know, the drama of the pandemic is real enough without doing everything possible to exaggerate it. But everything is being done to exaggerate it. The media love drama. If it bleeds, it leads. Comfort the afflicted, afflict the comfortable. And so we tend not to get, even from the most credible media outlets, we don't get context. Have you been told, for example, if you're a health professional, you already know this, but if you're not a health professional, why would you? Hospital census always goes up this time of year, always. Hospital census is minimal over the summer, every year, and it goes up in the fall. People get respiratory illnesses in the fall. There's more heart disease in the fall. Colder weather puts a strain on the cardiovascular system. Shorter days aggravate mental health issues, on and on it goes. Hospital census always goes up, and significantly, this time of year. Are you being told that? So, you know, how much of the change in hospital census around the country is COVID specific? Some of it, certainly. How much of it is just trends that occur every year because of the whole sweep of epidemiologic factors? Quite a bit of it. And here in Connecticut and in New York, it looks like it's almost exclusively those other factors. We're really not yet seeing any significant increase in COVID hospitalization or death. I say yet because we don't know the future, and my prior experience trying to project a timeline for the pandemic has humbled me, so I don't want to do it again. But I think we have a substantial degree of herd immunity here in the Northeast. And again, it's unfortunate that the rest of the country is getting there by means of incurring a high casualty count. As I've described before, I would argue that winning a pandemic war is high cases among people who are not vulnerable to adverse outcomes, low casualty counts by protecting those who are. So we're not doing that now. We're suffering both high case counts and high casualty counts in many parts of the country, but not those parts of the country that were hard hit in the beginning, which do continue to suggest significant approximation to overall herd immunity. So that's my tale of left and right and wrong. The other bit of right and wrong is I do believe now, as I did at the start, that the right way to have gotten safely through this pandemic, and it's not mattering anymore because we're so far into this for SARS-CoV-2, but you know, this will not be our last experience with a pandemic pathogen, so ideally we'll learn these lessons for next time. The right way through is to take stock of who's at risk, who's not at risk, and to risk stratify the population and tailor policies. If the pathogen is not a one-size-fits-all threat, policy should not be so blunt and indiscriminate as to be one-size-fits-all. We should look across risk tiers and make suitable adjustments. And again, I also think we have to leave the sanctimony and the self-righteous moralizing behind it. You know, if every last death from COVID is inexcusable, then why don't we shut down schools until we can achieve the prevention of any possible death from a road accident, riding a school bus, or commuting to school. As things stand, we are shutting down schools. I have to infer it's not to protect the kids, it's to protect their parents and grandparents because of high levels of community transmission. And I will leave out of this discussion, which is already going to be a lengthy one, the ongoing discussions about, does it make any sense to have restaurants and bars open but to close schools? And I would argue, along with many of my colleagues, no, it makes no sense at all. Keeping schools open should be the top priority, although I have great sympathy for what we're doing to the restaurant business too. But in any event, it just, it makes no sense to talk about zero tolerance when we tolerate deaths from highway accidents. We don't have a moratorium on all driving. There are injuries and deaths that occur in school buses. We don't decide, okay, we can no longer send our children to school, and on it goes. So there are many potential lessons to learn here, but along with leaving the sanctimony behind, uh, it absolutely does make sense to think in terms of total harm minimization, minimizing the harms caused directly by infection and the harms imposed on society by indiscriminate interdiction policies, and to achieve that by risk stratifying the population and matching the remedy to the level of risk. I thought that was right in the beginning. I've been looking on and, to the best of my ability, following all of the data about the pandemic these long months, and I still think that's right. Okay, so where are we now? Well, we're on the brink of the Thanksgiving break here in the United States. So let me take this opportunity to say, in spite of all the mayhem, I hope that all of you who have an upcoming holiday are able to enjoy it, are able to have some respite, ideally solidarity with family. The CDC has advised against getting together with extended family for the holiday. I won't speak to that. I won't speak to it because it's not my place to oppose the position of our official public health agencies. In fact, the work that I did at Yale for many years was funded by the CDC, so I have colleagues there. I work closely with them. That really is where the official advice should come from. In fact, it's nice to see them doing their job. They've been so hamstrung by the current administration that very often they fail to do their job. But issuing that kind of guidance is their job. And, frankly, if you're watching this, you're a grown-up. It's up to you to decide whether you're going to follow that advice or not. I have an opinion, but my specific opinion about that is simply that you have access to the CDC position, and they're telling you why. Obviously, the risks of convening are greater than the risks of not convening, but depending on the specific circumstances in your family dynamic, there may be risks of not convening, minimally. The mental health effects and so forth. So again, you have the relevant information to make your decisions on that topic. What about the good news around the next ban about vaccines? Well, it does look encouraging. Again, I think given the very significant surges in cases and casualties in many parts of the country, I wonder when the vaccine's ready, even if it's soon, how much we're going to need it, because it may be that so many of us have been exposed that the portion of the population that remains unexposed and non-immune is pretty small. But there will still be some portion of the population that never got exposed to this virus, and the vaccine will help us exit the pandemic. You've heard about two vaccines, Pfizer's and Moderna's, and both of them look promising. But here too, I guess it's back to the media mantra, afflict the comfortable, comfort the afflicted. So we've been afflicted with all kinds of horrible news about COVID. So when there was good news about the vaccines, it was time to comfort us. And just like the bad news is over dramatized pretty consistently, I think in some ways the good news about the vaccines has been either over-dramatized or at least oversimplified. Just so you know, in both cases, the trials by Moderna and Pfizer enrolled many thousands of people, but in both cases they did a data analysis when they had a total of about 90 cases of demonstrable infection with SARS-CoV-2 among those populations. They randomly assigned people to get the vaccine or a placebo, and then waited to see who got infected. So out of those many thousands in the Pfizer study, it was 42,000 people. There were a total of about 90 total infections, and 90% fewer in the vaccine group than the control group. So about 80 infections out of the 90 occurred in the control group, the placebo group, and just under 10 of them in the vaccine group. So it's 90% fewer. That's great. Okay, that 90% effective is the figure we've all been hearing, 95% effective. Sounds very good. Indeed, it is good and encouraging, and I certainly don't want to discourage the optimism attached to that. However, these data pertain to the period 7 days after a second dose of the injectable vaccine. So everybody participating in the trial got an injection, and those in the active treatment group got the vaccine. Then several weeks later, they got essentially a booster dose of the vaccine, and 7 days after that, the reduction in infection was 90%. Okay, that's good, but it means, first of all, that the vaccine campaign doesn't just need to reach everybody. It needs to reach everybody twice. And it doesn't really tell us much about the duration of that protection. If that's a time of peak protection a week after a booster dose, is it 90% protection a month after? Or does it start to drop off? And again, I don't want to attenuate the optimism about the vaccines. I think they're important, but there's a lot we don't know. If I were a peer reviewer looking at these studies, I would be asking a lot of questions and saying, before this is ready for prime time, you guys have to fill in an awful lot of blanks here, and I feel that way. Now, of course, we're on a fast track, and Pfizer has already asked for emergency authorization from the FDA so the vaccine can be deployed maybe even before the end of the year. And given what's going on with viral transmission, I do think that makes sense. But to be clear, based on the data we have, the vaccine is both vaccines, any vaccine, likely to be quite far from a panacea. There are going to be logistical challenges, production challenges, distribution challenges, and then the need to reach everybody with 2 doses, and then a lot we don't know about the duration of protection. So it's really just one component in what should be an overarching policy to get us through this. So yes, encouraging, yes, there's cause for optimism. But again, with the level of viral circulation currently playing out in the United States and much of the world, there are very large populations that are now well on their way toward herd immunity with or without a vaccine. The vaccine will just help us complete that job. One of the other misfortunes of all of this is that very term, herd immunity, has taken on political freight and has become something that is seemingly fraught and objectionable. And again, all that ever really meant is enough of us are immune that we stop transmitting this to one another. And so those of us who are immune are protected. Those of us who can't get it from us are protected. The frail and elderly who could never be exposed to this safely now can't get exposed because all of us who are immune are dead ends. Whether you get there by means of having had the infection or being vaccinated, it's the same end game. It's the same goal, herd immunity. Everybody's protected because the virus just can't work its way through the population anymore. It's not as if SARS-CoV-2 is going to disappear from Earth. It'll still be out there. And there will still be some people who are vulnerable to it because they don't get the vaccine, or the vaccine's ineffective in them, or they have impairment of their immune system because of some other condition. There is no circumstance where everybody in the world is immune to this germ. But there is a circumstance where enough of us are immune to this, either after an infection or after the vaccine, that everybody else is protected too, and that's what we're aiming for. So that's where we are, and that's sort of what's front and center now. Again, really unfortunate, the casualty counts mounting up around the country, but not seeming to do so in those parts of the country that were, or world, that were hard hit early on. If the whole population, including the vulnerable, older people, people with chronic disease, were exposed already, then those people prone to get really sick from this infection got really sick. Those prone to die died. And so we're really not seeing that occur now in New York City or Connecticut because it already happened here. It didn't already happen in much of the country. It's happening now. It didn't already happen in many populations around the world. It's happening now. but there will be a decline in those casualty counts, just as occurred in New York City, just as occurred in northern Italy, and we're probably well on our way. And so, again, the timing of that resolution relative to when the vaccines are available will be interesting to watch. So there you have it. This is a lengthy reflection. I also recognize this is a bit more rambling. I've tried to be as topical and specific with these as I can be, but this is where I find myself now. There's so much going on, so much news. The sort of pressurized coverage of COVID has been so amplified over recent days and recent weeks that there really is no single issue to resolve for you. As best I can. There's just a lot to reflect on, so I've done my best here to share those aspects of the pandemic that are occupying my mind, and to share those reflections in the hope that it offers you some useful perspective. It's really the best I can do. So once again, those of you who have an upcoming holiday, whether you're going to celebrate it in a traditional manner or not, I wish you and your loved ones, your family, your friends, a good holiday, some respite, solidarity, whether it's in person or achieved virtually, but a good holiday just the same. I think all factors suggest we are moving toward the light at the end of the tunnel, and there is reason to hope it will not be the headlights of an oncoming train. Things will be looking up soon, so keep the faith, and let's try to listen to one another. Let's recognize that nobody has cause to declare a monopoly on truth and understanding. I would say that the pandemic, if anything, really should have humbled us all and invites us to recall that in unity there is strength, and that we are better able to tolerate this kind of adversity together. And being together means a capacity to see one another, to listen to one another, to hear one another. So here's hoping we get better at that. Stay well.